over to you, Preeti.
All right. Can I have the first slide if that's okay? So I'll just put this out there. While I was doing the quality project for the FNF program, I realized that I came upon this quote, and it actually makes a lot of sense when you're going into trying to implement or bring about any change. So basically, while all changes don't lead to improvement, all improvement requires change. And I'm sure all of us who have gone through this program have actually understood that if you want to make any kind of improvement, we need to make a change. Next slide, please. So basically, the title of the project is to improve pain assessment in critically ill, ventilated, sedated, non-verbal patients with the implementation of a scale called as the behavioral pain scale. This was within the ICU. So just to give you a background, in ICU or the critical care units, normally pain is something which is quite subjective, and people are able to tell that I've got pain, and then we can get them to score on a pain scale. So it's a bit of a quantitative measurement. But what about people who are not able to verbalize? There are a lot of scales out there, but when I moved into this intensive care unit as a newly registered nurse in the UK, I had a patient. Basically, this project stems from my personal reflection. I had a patient who's had multiple surgeries. Patient was intubated, as in was on ventilator and had sedation going on. For a few days, the patient wasn't on any sort of, other than sedation, the patient wasn't on painkillers. A lot of sedation, the myth around sedation is that they are also painkillers, but that's not the case. And normally, if a person who's had about 3 surgeries will tell you, I am in agony, but what about this patient who's not able to tell? How do you quantify pain for this patient? That's how this project has come into picture. Next slide. So there was no specific tool for ventilated non-verbal patients. The verbal rating scale is ineffective, as I said, because the patients cannot self-report their pain. The pain is quite a complex, although it's quite simple, but it is very complex in the intensive care unit just because of sedation and there's underlying medical condition. It can be often underrated because if it's a nurse who is doing it, it wouldn't be the same as coming from the patient's point of view. The intensive care in the ICUs is mostly provided by nurses, and therefore what I felt is the perfect people to get this scale into and utilize it will be the nurses. Can I get the next slide? So a little bit about the scale. The behavioral pain scale is an observational pain tool. The validity and reliability of it has been done for years. However, basically there were 2 scales and I had to make a decision of either using these 2 scales. So what I did is I collected a baseline data from the ICU.
Hello, good morning. How are you? This is Maxine speaking.
Oh, sorry, Preeti. Let's make sure we've got everybody
for your area.
Speaking. Are you okay to do that, Maria?
For your area. I'm calling from anesthetics. There was a patient there.
There we go. Apologies
it's Naz that needs to be muted.
Yeah, it's Naz that keeps coming off mute, isn't it?
Yeah.
Yeah. Thanks, Preeti. Sorry about that.
Shall I go on?
You go for it. Thank you.
So I conducted a pre-data collection from the ICU nurses if they think having a scale is of use to them. And about 76% said that, yes, it will be great if I've got a scale, what I can use for the patients. So the scale takes into consideration 3 concepts. First is the facial expression, the upper limb movements, and compliance with ventilation. Next slide. This is how the scale looks. It looks a bit complicated, but I promise it's quite easy. It's just got a lot of information on it. I wouldn't go in much into detail over here, but basically what is that even though the patient is intubated, sedated, the body cannot lie. the physiological reactions and the physical, basically the fight or flight response in the body still remains. And this basically shows that even though you've sedated the patient, if the patient is in pain, you would be able to see that. They are able to tell you. The only thing is these are non-verbal behaviors, and these are very important. And hence the nurses, what I've always learned since nursing school, the nurses are the best observers out there. So I think this scale totally puts it into picture. Next slide. So the SMART aim was by December 2020, achieved 90% staff compliance with the utilization of this scale, especially in the ventilated, sedated, non-verbal patients in the unit. Next slide. And background, how this came into place, as I explained, it was, we were trying to keep most of the patients awake, but sometimes if the patient was not able to remain awake due to any reason, then the scale comes into picture. In order to, I did the data collection, I went to the stakeholders, spoke with them why I need this scale into the ICU. And the second step was to try and understand how will I implement it into the ICU. It's not just that I bring about a scale and I tell them, can you use this from tomorrow? I don't think any of my ICU nurses are going to be very happy about it. So I developed a driver diagram, and this was adapted from the Institute of Health Improvement. Next slide. So this looks a bit complicated, but what I've gone is from primary drivers, which are three things that I wanted to achieve, which is prevent pain, assess pain, and basically manage the pain. And from there, went on to the secondary drivers, divided those three simple goals into further goals, and tried bringing in change ideas, what I can bring into the ICU. So I can share this slide with anyone else later on, but there's a lot of information. I don't want to take much time. But I was able to utilize all these change ideas to bring about the implementation of scale. Next slide. So there were 3 cycles. The first cycle basically was presenting it out, this tool as of such, to the stakeholders, developing basic guidelines, laminating the tools, leaving them in the bed space, and updating the resource folder. The second, after doing this, got feedback from the staff what they would like. They wanted pictures, they wanted videos. So I was able to get in touch with the hospital communication team who've been helpful, and they helped me with developing a YouTube video so people could access it and just see how to utilize this scale. The scale was tested on 1 bed space with different nurses over a shift, and then accordingly rolled out into the ICU. The important thing that this all happened during the pandemic. So I work in ICU, as you know, so it wasn't the best time, but the staffs were very, very, very supportive. And they actually, and as you can see in the next slide, I will share with you, the scale has been successfully taken up by everyone. So it wasn't just the ICU nurses who came into the ICUs to work. It was all the redeployed, the retired nurses, and everyone took on the scale on board, and they were very helpful. The next slide, please. So I've just shared the result, how basically the scale was able to meet actually more than 90%. The only time that it was not able to be utilized is when there was no training. But once the trainings were into place, and I was able to cover about 220 nurses, yes, the scale has been quite successful, after which I used their feedback, whether they felt this scale was helpful to them, and about a lot of people, about more than 50% said that they felt the scale was extremely helpful. Next slide. Learning personally from this is that during the pandemic, the ICU capacity was almost triple. They had a lot of redeployed nurses, ODPs who've come in, but they all took these things into practice. They were able to learn and utilize it. Now the tools are a part of daily ICU assessments, and we actually monitor the usage of these scales. And as you can see, there are quite bottom feedbacks of what I was able to collect, and they felt it was quite useful for them. Next slide. And that's my references, and that's it.
Fantastic, Preeti. Liz, could I ask for your reflections on Preeti's presentation?
Sorry, I had trouble coming off mute, but hopefully you can hear me now. Preeti, what an amazing piece of work, and a really good application of the QI methodology. And I think recognising and managing pain is so important to the nursing role, isn't it, in how we provide care. And I think the tool that you've developed is really powerful. And I think what you've really cleverly done is picked up on those non-verbal cues that you only learn by experience. And often it's the much more experienced nurses that can pick up these things, can't always articulate them either. And you've applied it in a way that can teach others how to use it, and it can be applied consistently. And I can see that actually this is going to have much wider application than ITU. I'm thinking perhaps when people are looking after those that may be confused or have dementia, I think some of this could be really very important work. But and I think just listening to you, I've just been blown away. And I think something that you may have heard before about the standard you walk by is the standard that you accept. I think each and every one of you that have presented today has shown that actually you're not going to accept anything but the best for your team, for your colleagues, and for your patients. And I'm very humbled to hear of just this amazing work. It's fabulous.
Thank you, Liz. Thank you. And Yvonne, what do you think Florence might say about Preeti's presentation? Oh, you're on mute still, Yvonne.
Forgetting all these buttons and this technology. I mean, she would also be blown away. I mean, the way in which you have developed rigorously, the way in which you've handled the project, the research base, your data collection, then your implementation, your assessment of your outcomes. I mean, everything. She would be so thrilled. So, I mean, just very, very well done. And make sure you publish it if you haven't already. Okay.
I will put my hands up right now, Preeti, and say I will help you do that. So absolutely, that was exactly what I was going to say, Yvonne. We need to get this out into the wider domain. Thank you so much, Preeti, and well done.